Myasthenia gravis means grave muscle weakness. This autoimmune disease which affects skeletal muscles normally manifests itself as follows. The afflicted persons would normally wake up in the morning feeling just fine. However, as the day goes on, they start to feel weaker and weaker, and this arises from regular repetitive daily activities such as eating and chewing. The extraocular muscles, which move the eye and the eyelid, are also part of the skeletal muscles. So, in some patients with myasthenia gravis, we may observe the following symptoms: diplopia, which is double vision, as well as ptosis, which is drooping eyelid, in these images. As for the epidemiology, it's about 8 to 10 cases per million, and the numbers are going up. Females are far more affected than males under the age of 30. However, after the age of 50, it is believed males and females are equally affected. Before we get into the details of the pathophysiology of myasthenia gravis, a quick recap of synaptic transmission at the neuromuscular junction. Here we have the vesicles loaded with the neurotransmitter acetylcholine. Upon release, acetylcholine binds to nicotinic receptors. This leads to graded potentials at the neuromuscular junction. The graded potentials lead to action potentials, and eventually we have muscle contraction. After acetylcholine has completed its physiological activity, it has to be broken down by a post-synaptic enzyme here known as acetylcholinesterase. Here again, this enzyme breaks acetylcholine down into acetate and choline. Choline is taken back up into the presynapse, where acetylcholine is reformed and brought back into the vesicles. Now to the pathophysiology of myasthenia gravis. To simplify, I'm using asterisks color-coded for the different steps. We start with B cells that generate autoimmune antibodies against nicotinic acetylcholine receptors. Now these antibodies target the receptors, bind to them, and block them. Acetylcholine is no longer able to bind to them, so the muscle is unable to contract. In some cases, here, also the complement pathway is activated. This worsens the conditions, as it may lead to inflammation, destruction of the muscle cells, and eventually this reduces the number of acetylcholine receptors on the surface. In some patients, there are other antibodies produced, indicated by this black asterisk. These antibodies are known as muscle-specific receptor tyrosine kinase antibodies. Now, these antibodies target proteins inside the cells. In rare cases, myasthenia gravis can also present as paraneoplastic syndrome. This is an underlying cancer, different types of cancer, that generate an immune response similar to myasthenia gravis. Here's again a summary of the pathophysiology of myasthenia gravis. We see here an intact neuromuscular junction with invaginations, so we can pack a large number of acetylcholine receptors. As the B cells start to generate the antibodies against the receptors, at some point the receptors will start to break down. The surface area decreases here. It decreases because the invaginations are lost gradually, and eventually the number of acetylcholine receptors on the surface goes down. A myasthenic crisis is a life-threatening condition where we see decreased function of breathing muscles. The patients may not be able to breathe on their own, so they need to be mechanically ventilated. Now to the diagnosis. 2 tests. They are based on improvement of the symptoms of eyelid tripping. In the first test, hydrophonium test, Tenzelon, we apply a substance, for instance, hydrophonium chloride. This substance inhibits the activity of acetylcholinesterase, so acetylcholine will remain in the synaptic cleft for a longer period of time. So the symptoms improve. According to the same principle, in the ice pack, we have a bag filled with ice, which is placed on the eyelid. This cold temperature decreases the activity of acetylcholinesterase, among other proteins, which means the degradation of acetylcholine is slowed down. It remains in the synaptic cleft for a longer period of time. Symptoms improve. As for the treatment, the first line of treatment is based on the application of acetylcholinesterase inhibitors such as neostigmine, pyridostigmine, and there are many others. You can also apply immunosuppressive drugs, for instance, prednisone, azathioprine, or cyclosporine. Thymectomy induces remission in 35% of the cases and improves symptoms in another 45% of patients. I hope this was helpful.